Hello, this is Jennifer Barney. I am a AGA CNP student at UTEP presenting my H&P for the summer adult and critical illness class. I'll be presenting my H&P on a patient who came in with chief complaint of abdominal pain. She is a 56-year-old Hispanic female with a past medical history of hypertension, diabetes, hypercholesterolemia, seizure disorder, anxiety, depression, neuropathy, and CKD2, who presents with abdominal pain, nausea, and vomiting for 2 days. The patient denied any fever, chills, or body aches. She reported pain to the left upper quadrant and described it as throbbing and shooting pain. Denied any changes in her bowels, reports vomiting as well, roughly 5 times over the course of the 2 days. She also reported poor PO intake. Past medical history includes hypertension, diabetes, hypercholesterolemia, seizure disorder, anxiety, depression, neuropathy, CKD2, sleep apnea, and chronic hypoxemia requiring O2 therapy at home. Past surgical history includes cholecystectomy in 1999, hysterectomy, knee surgery, and left femur fracture with repair in 2011, secondary to a fall. Patient has no known drug allergies. Home medications include Levemir 20 units QHS, lisinopril 10 mg POQ daily, metoprolol succinate 50 mg POQ daily, simvastatin 40 mg QHS, and insulin regular AC and HS per sliding scale provided by her PCP. The patient lives at home with her daughter and grandson. She is unemployed, does not drink, and has never smoked. Past family history is significant for hypertension, diabetes, and chronic kidney disease. On review of symptoms, the patient denies any fever, night sweats, weight loss, or lymphadenopathy, no vision changes or changes in her hearing, no vertigo, denied any weight change, heat or cold intolerance, however did report polydipsia. Cardiovascular-wise, she denied any chest pain, palpitations, edema, or orthopnea, no shortness of breath, dyspnea on exertion, or cough. She did report nausea, vomiting, and changes in her appetite as well as abdominal pain, but denied diarrhea, melena, hematochezia, or changes in her bowel. Patient also denied any dysuria, frequency, or urgency, no joint swelling or pain, no headache or change in vision, smell, or taste. On physical exam, the patient's vital signs were blood pressure 178/98, heart rate 91, saturation is 95% on 2 liters, which is her home use requirement. Her temperature was 36.9 and respirators were 18. Patient was a well-developed, well-nourished Hispanic female, appeared older than her stated age and in no acute distress. She had no lymphadenopathy or masses, no thyromegaly, carotid pulses were 2+ and equal bilaterally. Visual fields appeared intact, chest expansion was symmetric and clear to auscultation, regular rate and rhythm, cardiovascularly, no murmurs, rubs, or gallops. Her abdomen was soft, bowel sounds were present. She did have tenderness to palpation to the epigastric and left upper quadrant region. Extremity sides were symmetric, temps were warm, skin was tan in color with poor turgor. Gait was normal, she did not use any assistive devices, and cranial nerves were intact grossly. She was alert and oriented and cooperative. Laboratory studies were done. She had a sodium of 128, chloride 93, BUN 42, creatinine at 2.3, and EGFR of 24. Glucose came back at 629, phos level at 1.9, and MAG 1.6. Lipase level 3,171. WBCs 15.36, RBCs 3.71, hemoglobin slightly low at 11.4 and hematocrit 35.5, and patient's ketones were negative. So this patient is a 56-year-old Hispanic female with a past medical history of hypertension, DM2 with complications, hypercholesterolemia, seizure disorder, anxiety, depression, CKD2, sleep apnea, and chronic hypoxemia requiring chronic O2, who presented with abdominal pain, nausea, and vomiting for 2 days. She was found to have a markedly elevated glucose on admission with her negative ketones in severe dehydration and was to be admitted to the ICU. Diagnoses include acute pancreatitis, markedly elevated glucose, hyponatremia, acute renal failure, and chronic kidney disease stage 2, uncontrolled hypertension, dehydration, hypophosphatemia, hypomagnesemia, and anemia of chronic disease. The patient was still pending a abdominal CT when we rounded on her. The plan was, however, to admit the patient to the ICU for intensive monitoring and IV insulin therapy. She was going to be kept NPO. The patient had already received several boluses in the ER of normal saline and to be started on normal saline at 125 with the goal of rechecking her sodium every 12 hours until normalization. Patient was started on IV insulin per the ICU protocol, and we ordered an A1C for the morning labs. For the renal function, avoid any nephrotoxic agents, to include the A1 or the ACE inhibitor that she was taking at home for blood pressure control. The patient did have a nephrologist, so we were going to consult the patient's nephrologist for further recommendations, and added hydralazine for systolic blood pressure greater than 160. Her beta blocker was continued. The patient was not a candidate for the ICU replacement protocol for her electrolytes due to her kidney function. However, we were going to replace the phos and the mag and then check iron studies in the morning. And that was my patient. I appreciate your time.